I'm Anna Marson, registered psychotherapist in the province of Ontario, and today I'm going to be discussing PTSD with you, post-traumatic stress disorder. And I think that this is such an important topic for discussion because, as frontline clinicians will tell you, trauma is an epidemic that underlies many mental health concerns, and it's often very overlooked in our systems. As we know, many of our societal systems, our judicial, political, and health systems do not practice from trauma-informed approaches. And so it behooves us as clinicians to be trauma-informed and to offer trauma-specific services because they're so needed. So in order to qualify for a diagnosis, there are a couple diagnostic criteria required, and these criteria apply to children over the age of 6, youth, and adults. So first, there must be an exposure to a traumatic event, so an exposure to the threat of serious bodily injury or death, or perception of these types of threats, or to also one's sexuality. It could be a sexual threat. So either having that kind of direct threat or experience happen, or observing a trauma happening to someone else, or it could be that they've learned that a loved one, a relative, or friend has been exposed to a traumatic event through violence or an accident, or they could have repeated or extreme exposure to graphic traumatic content, as we see so often in first responders on the job. And so then there are a couple of different clusters of symptoms. So the first is intrusive symptoms, such as unwanted memories of the event, dreams or nightmares of the event, dissociative symptoms, or reliving in flashbacks. It could be also increased distress, emotional or affective distress, or physiological responses in response to trauma-related content, something that's reminiscent of the trauma. One or more of those symptoms must be present. We also see another cluster of symptoms is avoidance strategies to avoid internal and/or external reminders or cues associated with the trauma. We also see disruptions in cognition and affect following a trauma. We also see disruptions in autonomic physiological arousal. So that could be seen in terms of increased agitation and anger or irritability that's unprovoked. That could be self-destructive behaviors. It could be hypervigilance, an increased startle response, impaired concentration and cognition, and/or sleep disturbances such as frequent waking or early morning waking. So one or more of those symptoms must be present as well. So all of the symptoms must be present for over a month. They must not be attributable to another medical or substance-related concern, and they must cause clinically significant levels of distress and/or impairment in functioning in order to receive a diagnosis of PTSD. And in terms of assessment measures that I would use to inform my diagnosis, I would draw on the clinician-administered PTSD scale, or the CAPS. It's got wonderful psychometric properties. It has a child and youth version, and it's very specific to PTSD, unlike some other measures. And I really appreciate that the CAPS does assess previous exposures to historical traumas, because research shows that repeated exposures to traumas can have a cumulative effect and can increase a person's susceptibility to developing PTSD. So that's really important information to have. And in terms of treatment approaches that I would recommend, cognitive behavior therapy, or CBT, is an evidence-based approach for PTSD, and that will center on working with the distorted cognitions and beliefs that can result after a trauma, as well as some behavioral exposure therapy techniques to gradually and safely help the person become confronted with some of the stimuli associated with the trauma, while helping them also de-escalate some of their autonomic nervous system arousal. So that's a great approach, as well as sensory motor psychotherapy developed by Pat Ogden. While this approach will address some of the emotional and cognitive aspects of how a person can be impacted by trauma, it does center on a body-oriented approach to noticing the stress responses, so looking for indications of hyperarousal, the fight, flight, and freeze responses, or hypoarousal, so the shutting down, dissociative symptoms, and helping the person scan and helping the person regulate those using experiments that are about posture and movement to release how the body is impacted by stress through mindfulness-based strategies in session with the client. And And I've personally witnessed how transformative that approach can be, and it's a really great technique to use. And I also recommend using a triphasic approach to any trauma treatment. So this can be an overarching framework that you can use any evidence-based modality within. So the triphasic approach was encouraged and recommended by Judith Herman, and the first phase of the triphasic approach is developing safety and grounding strategies to help people better manage some of the intrusive symptoms seen after PTSD so that they feel more empowered, they feel safer. Once people feel better resourced within that phase, then they can go on to the second phase, which involves deeper trauma processing, so a remembering and a grieving related to specific trauma content. Once that occurs, then we can move on to the third phase, which is a reintegration. So having experienced and been fundamentally changed in some ways by the trauma, how can a person live their best life, reintegrate into different aspects of life with post-traumatic growth in mind? And so it's always important to be triphasically approaching trauma. For people who are a bit treatment resistant, or if their symptoms are really debilitating, there are FDA-approved SSRI antidepressant medications such as Zoloft or Paxil, or there are anxiolytic medications that their doctors or their psychiatrists can consult with them about. There have been preliminary studies about cannabinoids such as CBD and THC being other treatment options, as well as neurofeedback has shown preliminary evidence in studies for treatment of PTSD. So there's a lot of different options. There's reason to be hopeful, and there's a lot we can do for folks to help their recovery. That's all the time I have for today. Thank you so much for listening, and good luck in your efforts to be trauma informed.